Good morning, everybody. My topic of today's discussion is analysis of anatomical and functional outcome in optic pit maculopathy surgeries. Optic disc pit was first described by Waite. Incidence is 1 in 10,000, and maculopathy is seen in 25 to 75% cases of optic disc pit. The origin of fluid is still controversial. There are two major theories. One is from vitreous and other is from cerebrospinal fluid, but there's a direct communication between the subarachnoid space and subretinal space. Again, treatment modalities are controversial. Vitrectomy is the preferred one. Plugging the optic disc pit with different materials like graft like autologous platelets and scleral graft are tried. Ours is a retrospective study of 13 patients done from 1st September to 30th September. A detailed history and ocular examination was done. All surgeries was done by a single surgeon. Previously, we used to do 23 gauge vitrectomy. Now we have moved on to 25 gauge. PUD induction was done and a graft 0.5 into 0.5 mm was taken from supratemporal sclera and plugged into the optic pit, and careful fluid oil exchange was done. Coming to the result, we had 5 males and 8 females. All cases were unilateral. One patient had retinochoroidal coloboma in the other eye. Other patients had normal eyes. Mean preoperative vision was 636. Median preoperative vision was 636, which improved to 618 at 1 year. Coming to the OCT changes, when evaluating the disc, we could see there was a hyporeflective space inside the optic disc pit, which was postulated as collection of fluid, and we could see there was a connection from the optic disc pit to the inner retina. This figure also shows a connection from the optic disc pit to the inner retina. But post-operatively, this is the scleral graft of one patient who was followed up at 1 year. We could see that the tract has disappeared and the fluid has decreased. Coming to the macula findings, we could see that 76 patient had outer retinal schisis and 72.2 had inner retinal schisis. The fluid first appeared in inner retina in all cases. Post-operatively, fluid resolution was seen first in inner retina and the outer retinal fluid was last to disappear. Central macular thickness, there was a reduction of 35 to 50% in 40% of cases and 50 to 70 in 30% of cases. Normal OCT was seen in 10% and attached retina with thinning was seen in 20%. When coming to the complication, what we see was raised intraocular pressure was seen in 3 patients, which was managed with anti-glaucoma medications. 1 patient each was there with cataract, rhegmatogenous RD, recurrence of edema, and dislodged plaque. For rhegmatogenous RD, we did a silicone oil in situ, and this was the patient who had recurrence of fluid. At 1 year, the patient had a drastic decrease in central macular thickness, but at 2 years, we could see there was recurrence of edema, and which was treated with topical steroids. And the patient who had a dislodgement of plaque had similar decrease of central macular thickness. So what we found was that in OCT, there was a fluid tract which was seen from the base of the pit to inner retina, and post-operatively, the inner fluid was first to disappear and also first to appear and also first to disappear, which was in favor of the CSF theory. But none of our patients had PVD and all patients was induced PVD, and there was no vitreomacular traction clinically or in OCT. So we made a humble attempt to derive the pathogenesis of optic disc pit maculopathy, which was depicted through this animation. So optic disc pit is a failure to closure of the embryonal fissure. We can see when the optic disc pit develops, there is a fluid collection pocket which is formed beneath the pit, and when the egress of fluid to the retina may not be an acute process, it can be a chronic process. In cases like maybe a CSF fluctuation, the fluid slowly egress into the inner retina and the retinal thickness increases. But when we are putting a graft into the pit, we can see that there is a mechanical obstruction of this path and the central retinal thickness decreases. So what we like to conclude is that optic disc pit maculopathy may be a CSF in origin. Scleral plug offers a mechanical closure than an anatomical closure, and more discussion has to be needed in this entity because it's as we have seen, the mean age group is 35 years, and also 25 to 75% of patients with optic dispute can develop maculopathy later. Thank you.
How do you decide the size of the plug?
So we initially, when we were doing a 23 gauge, we could insert a plug more than 0.5 mm into 0.5, but for the ease, we have taken at 0.5 into 0.5 mm
No,
for
no,
25
the
gauge.
reason is you say it's a mechanical closer.
Yes, sir.
So you need to have a snugly fitting plug there.
No, sir.
If it is a larger one, again you're going to cause a lot of nerve fiber layer damage. If it's less, it's going to dislodge. So you need to have a precise dimensions how you decide that.
So we also believe not only because of the mechanical effect, because of the manipulation also, some obstruction in the tract has been happening. Because for one case we saw that even though the plug was dislodged, there was a result was similar. So maybe not only the plug, but also manipulation also might have caused a change in the tract.
You also know there's a fluctuating course over a period of years, natural course we know.
Yes, sir.
So really you think that with surgery help, but it's like a natural course. Probably if you reduce sometime, as you say, CS pressure and all those things, and we have seen that. So how you are sure about it? Your technical surgery works in those cases probably.
Yes, sir. Definitely, we have seen a decrease in CMT, and also base 3-line in 40% cases had 4-line increase, which is a good result. And this is so in young patients. So I think we can call for a surgery than observing.
Dr. HEMA, did you have any control group in this study?
No, sir. Which all patient who had this optic disc maculopathy, we had undergone surgery. But
what Sarah was telling that
yes,
whether
sir.
you have a spontaneous closure of the optic pit, even without giving a scleral plug.
Yes, the thing is, some patient who had denied surgeries, only we didn't do surgeries. But when we follow up, no, they really had an increase in central macular thickness. But when we did surgery, none of the patient had an increase. No patient had worsening, and 40% had better reduction in CMT.
No,
and what was the nature? So what was the nature of the graft? Autograft?
Partial thickness scleral graft, sir.
Okay.
Taken from supra. Sir, 25 gauge, we can put a 0.5 into 0.5, sir.
Okay.
The autologous graft.
Yes, sir.
Same patient.
Yes, sir. Same patients.
Last question I had, that since you brought out a very important point which I caught, that you feel that the manipulation in the pit can close the hole. So I think there's a way, like, means we could consider that rather than putting a graft, like, you can use a Finis loop or a Tanos diamond duster and try to, sort of physically close that, or, what about that
Sir,
idea?
that is one patient we had only since 1 year follow-up. So we don't know what will happen in future.
Correct.
But that's one of our postulates, sir.
Okay, great.
And what's the thickness? How do you determine the thickness of the graft?
Partial thickness around below less than 40% we can take, sir.
Thank you, madam.